To start, would you mind telling us a little bit about yourself and what your clinical research work at Fred Hutch focuses on?
Sure. So I'm Lara Davis. I am a professor of medical oncology at Fred Hutchinson Cancer Center, and I'm the program director for the sarcoma program and the Anderson Family Endowed Chair of Sarcoma in the Division of Clinical Research. My research and my clinical footprint is all focused on sarcomas, and that's a very interesting group of cancers, and I'm thrilled that you're highlighting it this month.
For readers who might be hearing this word sarcoma for the first time, how would you describe what it is and how it differs from other cancers that we hear a lot about?
Yeah, so sarcoma, as just one lump of cancers, is rare. So by the rare definition, even if we put all the different kinds of cancers that fit into that sarcoma umbrella together, it's still rare. And that umbrella encompasses over 100 different cancers. So you can imagine that each one of those 100 or so cancers is very rare. And I think one of the things that people think about, if they've ever heard about the term sarcoma, is pediatric cancer. So pediatric cancer is rare as well. And sarcomas make up a bigger percentage of the kinds of cancers that happen in kids than it does in adults. So often when people have heard of a sarcoma, it's a sarcoma that affects children, such as osteosarcoma or Ewing sarcoma. But there's a really wide variety of different sarcomas, and the number that occur in non-kids, so young adults and older adults, is actually quite a lot more than happens in kids. And probably about half of all sarcomas happen in the adolescent and young adult age group. So that's between age 15 and 40. And that's actually how I got really interested in sarcomas, is my interest in that age group of patients. And because a significant portion of sarcomas happen in that age group, I kind of got more and more interested and involved in sarcoma work.
So, sarcoma is sometimes described as a group of many different cancers rather than one disease. Could you help us understand the main categories, including how soft tissue sarcoma differs from bone cancer?
Sure. So sarcoma, that sarcoma umbrella just means a cancer of connective tissue. And that's really the difference between the cancers you've heard of: breast cancer, colon cancer, prostate cancer, and sarcomas. So sarcomas are mesenchymal in origin, whereas all of those other more common cancers are carcinomas. So there's really just a very basic difference between the common carcinomas and then these sarcomas of connective tissue. One thing that's super unique about all of them, whether they're bone or soft tissue, they can happen anywhere in the body, and they can happen at any age. So I was talking about happening about half of them in adolescent and young adults, but they can happen in infants. Babies can actually be born with a sarcoma. The elderly can get sarcomas, and really anywhere, any age in between, and also anywhere in the body. So brain to toe, anywhere in between. Very different than a breast cancer, which arises in the breast most often in folks who are later in life. So there's these kind of fundamental differences between sarcomas and carcinomas. And then within that umbrella, you mentioned the difference between bone sarcomas and soft tissue sarcomas. So about 15 to 20% of all sarcomas start in the bone. And that's osteosarcoma, Ewing sarcoma, chondrosarcoma. Those are the most common bone sarcomas. There's actually not that many different kinds of bone sarcomas. The 80% of sarcomas that are soft tissue sarcomas is where we get into all those different subtypes. Probably the most common ones within that 80% are gastrointestinal stromal tumor, or GIST. That's a sarcoma. Liposarcoma, leiomyosarcoma, and then like undifferentiated sarcomas, which are tumors that really they don't look like anything anymore. They just look like cancer. So we can't put that descriptive term before sarcoma. Like with liposarcoma, that started out as a fat cell. So those started out in the fat, leiomyo started out in smooth muscle. And that's where you can start to see how these cancers could happen anywhere, right? You've got smooth muscle in every little tiny artery in your body. So that could give rise to a leiomyosarcoma.
Are there any common misunderstandings about sarcoma that you find yourself correcting with patients?
I think less correcting misunderstandings, but more just patients want to know why. And with some cancers, we know the risk factors, right? We know smoking or just being older, like having gone through a lifetime of exposures to different hormones in your body increases your risk over time, and various things in your diet. But with sarcomas, we don't have those things that are causing them. It tends to be a singular genetic event that causes sarcomas. 20% of sarcomas are actually driven by a rearrangement or a fusion in the DNA. So they have extremely boring genetics in the tumor, but just one change, and that one change is enough to drive the cancer. So that's things like Ewing sarcoma. There's a simple switch in the DNA, but that switch is so bad that it is all that's necessary and it is sufficient to cause that sarcoma. And there's a number of others, 20%, that are like that. And even though we understand what that DNA change is, because we have the sequencing, we get that result, helps us make the diagnosis. But unfortunately, most of those we don't have a drug for yet.
Are there any symptoms that you would want someone to bring to their doctor, even if they seemed like small or easy to dismiss, like things
Yeah,
that would tend to get overlooked?
yeah. Unfortunately, a lot of times with sarcomas, it takes a long time to get diagnosed because they don't present with something super obvious. Uh, one thing that has been around for quite a while now is this phrase: if it's bigger than a golf ball and growing, think sarcoma. So this is getting to those soft tissue sarcomas, and lots and lots and lots of people have a small little bump somewhere, right? And 99% of those are going to be benign, not cancer, not something to worry about. But if it gets to the size of a golf ball and it's growing, then that's something that needs to get checked out. It still might be nothing, still might be benign, but that's something that's worth getting pictures. So usually an MRI is a CT or MRI. Sometimes it's okay to start with an ultrasound, but that's a fairly easy thing to remember. And usually people who have a golf ball size thing do seek care, but unfortunately, sometimes doctors who see 99% of benign things aren't attuned to the fact that something that's size of a golf ball and growing needs more workup. And this, there's been some studies, they're imperfect, but kind of looking back at how people presented. And interestingly, it's often not painful. So some people are reassured that they don't have pain, but pain is actually not a very good indicator. It really is that persistence. So it's a lump that's been there for 3 months or something, and it's growing. Those are the red flag things.
Are there any newer approaches, such as targeted therapy or immunotherapy, that are changing how sarcoma is treated?
Absolutely, and actually that's a main reason that I really enjoy the challenge of taking care of sarcomas. Right, it is hard to take care of cancer when something you've never seen before, even though you've been practicing for 15 years, is somebody with a diagnosis that you've never seen is showing up, and then that's hard, but it's also very interesting. And now that we're getting better specificity in our diagnoses and how each one of these sarcomas is kind of unique, there's more ability to think about, okay, we used to do trials where it was all sarcomas, just anything that's a sarcoma, we're gonna put into one clinical trial, and there was a lot of negative trials. But now that we're getting more specific about, okay, it doesn't make sense to treat a liposarcoma the same way that we treat a synovial sarcoma, the same way we treat a chondrosarcoma. So we're getting much more specific. And like, for example, GIST is a very unique sarcoma. It actually responds exceptionally well to targeted therapy. there are multiple different approved targeted therapies that are absolutely life changing for patients with advanced GIST, and there's new ones coming. Multiple new ones in clinical trials now, others that are likely to get approved soon. Another thing would be conventional chondrosarcoma. So that's a tumor that actually I don't I don't see that often because as a medical oncologist, we don't have very many good treatments. That's a generous way of saying we don't have any good treatments for conventional chondrosarcoma. So while we have some things that might help a little bit, it's really mostly a surgical disease. So just cut things out if you can. But we participated in a clinical trial of a brand new class of drugs that actually seems to be more than doubling the progression-free survival of patients with conventional chondrosarcoma. Now, the drug's not FDA approved yet for any indication. I probably expect that it will be, but that's pretty exciting, right? Like, essentially, if I see a patient with chondrosarcoma today, I have to say, well, I've got these couple of things that have side effects, but might help you a little bit. But in a year, I might be able to say, I've got this drug that's pretty well tolerated and might actually help you live longer. That's a pretty exciting thing to be able to experience in one's career. All these new types of drugs and treatments. So for whatever reason, the pharmaceutical companies are starting to pay a little bit more attention to sarcomas. In the past, it's a small population out there, so there's a small group of folks to bluntly sell medicines to. So breast cancer, colon cancer, prostate cancer, much more of a hot field for drug development. But honestly, because the treatment options for sarcoma have historically been so limited, and patient survival has not been great for some of these sarcomas, there is an opportunity for some of these companies that they're starting to recognize that, okay, we could actually help these patients a lot, even though it's a small population. Maybe it's something we could focus on and get our foot in the door, and then go off to breast cancer or colon cancer or something like that. So in the past decade, we've had at least one drug approved for a sarcoma subtype every year, which is a big difference from when I just started. There hadn't been a new drug for a long time. So it's been an exciting time.
It's been a really exciting year for cancer research. There was the successful pancreatic trial,
Absolutely, yeah.
and then there was the drug that was the findings were just presented at the I don't know, is it ASCO? I'm not sure how to
ASCO,
pronounce
ASCO.
ASCO. Okay, at the
Yep.
ASCO conference, that was like a huge thing too. They got a standing ovation.
Yep.
Um, yeah, it's a really exciting time in cancer research.
Yeah, absolutely, absolutely. And the very first T cell receptor uh, modified cell therapy was actually approved, I don't know, 2 years ago for synovial sarcoma. So for a sarcoma subtype was the very first tumor that got a TCR cell therapy approved. So that's pretty exciting for little old sarcoma. Um, we actually had a big sarcoma presentation at ASCO this year, which sarcoma rarely gets the plenary stage, so it didn't get a standing ovation, but there was a liposarcoma trial that was presented there that we participated in as well, and the findings were a little bit of a no-brainer. Liposarcomas are driven by amplification or overexpression of CDK4. There's a whole bunch of CDK4 inhibitors out there because they work in breast cancer. So, if you treat the cancer driven by CDK4 with a CDK4 inhibitor, it works. And so it's good to finally have that data so we can now have a little bit more success in having the insurance companies help us out and cover the use of these drugs for this disease. Hopefully someday we'll actually have one that's on label with FDA approval, but that's a long ways off.
Yeah, we're making good progress though. This is very exciting. Last question. For someone who is newly diagnosed or for a loved one that's supporting them through a diagnosis, is there anything that you would like them to know?
The number one thing, if you are diagnosed with a sarcoma, or if someone suspects sarcoma, they really need to be assessed at a high volume sarcoma center. That is going to mean for most people in the country that they're going to have to travel a little bit. So, for example, we're at Fred Hutch in Seattle. We are the sarcoma center for the entire state, for Alaska, for Montana, for Idaho. There aren't sarcoma centers in every state. There aren't sarcoma centers in every city. And from European data, we know that patient survival is actually impacted by where they're treated. So rare cancers like sarcoma, if you have, if your doctor has treated, a handful, it's understandable that they may not know all of the latest data. They may not have all the tools and tricks. And this is a really multidisciplinary disease. And so even if there's one doctor at a center that knows a lot about sarcoma, if they don't have a surgeon, a pathologist, a radiologist, a radiation oncologist that also know a lot about sarcoma, you just can't get the same degree of care and level of care that really can improve people's outcomes. And access to clinical trials too, right? Clinical trials for sarcomas, really the way that we're coming up with all these new treatment options, where 5 years ago, we wouldn't have had the same options we have today, and the clinical trials we have today are going to help patients for sure in the coming years.